All right, good morning. Thank you for joining us for today's webinar, Perinatal Pregnancy, or Perinatal PrEP, sorry, PrEP and Pregnancy. For your information, all participants' microphones are muted today. If you have any questions you would like to be addressed after the presentation, please use the Q&A box that is located in your Zoom taskbar. Usually this is at the bottom or the top of your Zoom window. The chat box is also available if you have any comments or technical questions. My name is Savannah Holt, and I'm the Sexual and Reproductive Health Program Coordinator with the Saskatchewan Prevention Institute. The Prevention Institute is a provincial nonprofit organization that's located in Saskatoon on Treaty 6 territory and the homeland of the Métis Nation. Our organizational focus is to reduce disabling conditions in children using primary prevention methods. We raise awareness by providing training, information, and resources based on current best evidence. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We work in a variety of areas, including fetal and alcohol spectrum disorder prevention, maternal and infant health, early childhood mental health, child injury prevention, child traffic safety, parenting, and sexual and reproductive health. One focus of the Sexual and Reproductive Health Program is to provide evidence-based information on sexual and reproductive health that's accessible to healthcare practitioners and allied health professionals. The rate of individuals testing positive for HIV in Saskatchewan is nearly triple the Canadian average. In 2018, of the 168 new cases of HIV diagnosed, 71 were in females, and 83% of the female cases were identified as females of childbearing age between the age of 15 and 45. This highlights the importance of efforts to reduce vertical transmission of HIV between mothers and their children. Pre-exposure prophylaxis, or PrEP, is one highly effective strategy for reducing the transmission of HIV. Here to discuss perinatal use of PrEP is today's speaker, Carly Pozniak. Carly Pozniak received her Bachelor of Science in Pharmacy from the University of Saskatchewan in 2010, followed by the successful completion of her pharmacy residency in 2011. She joined the Positive Living Program in 2017, which is a multidisciplinary team comprised of physicians, a pharmacist, nurses, social workers, and case managers who all work together to provide care for people living with HIV and hepatitis C. Carly is passionate about sharing education around HIV medications with other healthcare professionals, students, and patients that will optimize the health and well-being of those living with HIV and help prevent new infections from occurring. In Saskatchewan, we are sadly still seeing high rates of new HIV infections, and we need a collective effort from all healthcare providers in the province to help stop this rise. Today, she'll discuss one of the preventative tools that are highly effective in preventing the spread of HIV. Thank you for joining us today, Carly.
Thanks so much, Savannah, for the introduction. And I'd like to thank the Saskatchewan Prevention Institute for inviting me to speak on this very important topic today. Some of you might be very familiar with PrEP, and others this might be a completely new concept. So I hope there will be something for everybody today, that you might learn a couple of things that you can go out into the community and start encouraging use of PrEP. So we'll get going here. I just want to take a moment to acknowledge this statement. As we gather here today, we acknowledge we're on Treaty 6 territory in the homeland of the Métis. We'd like to pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Just a little disclosure, I have received some speaker honorary in the past, and compensation for participating in advisory boards for Gilead and Merck. I just thought we'd start this off with a little bit of humor today. I think we've all kind of had enough of this COVID pandemic that's been going on, and a lot of us have been, attending presentations and meetings through the virtual means like we are today. So this guy right here is kind of living the dream. He's business on top and casual at the bottom, and nobody seems to know. So I assure you, I'm not doing that today. But so let's get going here. Some other things we'd like to focus on today is reviewing the clinical guidelines and procedures for pre-exposure prophylaxis, or PrEP, use in women that are trying to conceive, who are pregnant, or are breastfeeding. discuss the patients that would be ideal candidates for PrEP based on the risk of HIV acquisition, focus on the substantial benefit PrEP offers, and at the same time balancing potential risks, and then highlight some strategies that might increase the consistent use of PrEP once it's being prescribed. So what is PrEP? PrEP is the use of antiretroviral medications by an HIV negative individual prior to their actual exposure to HIV to prevent infection. Having adequate concentrations of antiretrovirals in the body already prevents HIV from incorporating itself into the CD4 cells and establishing permanent infection. So how HIV works normally, it targets those CD4 cells in our body, those cells that are responsible for some of our immune function. It finds those cells, uses those cells basically almost like a photocopier to make viral copies of itself, which in turn destroys that CD4 cell and then, promotes more HIV infection that continues replicating in that fashion. So that's why you end up seeing folks that are HIV positive with such low CD4 counts. And the longer someone is positive without being on medication or treatment, the lower that CD4 count tends to be. So in Saskatchewan here, Savannah did highlight a couple of figures in her introduction there. The Saskatchewan diagnosis rate was 2.4 times higher than the national rate in 2018. We don't have the 2019 Canadian data in yet, but this is a highly concerning rate. Also, if there's another infographic, if you look on the provincial HIV report, there are some parts of the province that are actually as much as 10 times higher than the national rate in terms of new cases. So I think that's highly concerning, sort of in the Prince Albert region, and it's where it's really been seeing a spike in cases. Of interest is that 47% of these new cases are female, and 7 in 9 of those new diagnoses in women were women of childbearing age. So I think this kind of highlights the need for discussing prevention techniques like PrEP and thinking about using them in our population of women. Because we've been actually in the last year, we've had several pregnant mothers that have presented with new HIV infection during pregnancy, which is the highest risk for transmission to the infant. Is when the mom is seroconverting in pregnancy. You can see a huge high spike in the viral load at the beginning, and then it kind of settles down to the kind of the set point. But as it does that huge spike with the viral load, that puts the baby at high risk of transmission. So why is PrEP an important preventative strategy to be using? There is increased risk of HIV acquisition in the conception phase, pregnancy, and early postpartum phase. Some of the reasons that have been identified for this are that there's increased conjugal sex going on. The body has a suppressed immune system during those times. There's increased genital tract inflammation, which makes it easier for the virus to kind of come in and establish itself. And there's decreased integrity of the vaginal epithelium. The incidence of HIV during pregnancy is 2 to 6 times greater than non-pregnant counterparts. And the risk of vertical transmission, so transmission to the baby, is 9 to 15 times higher in women diagnosed with HIV during their pregnancy. And so that's called seroconversion, when the woman becomes HIV positive. And like I said, the viral load is extremely high. Sometimes it can go up to 1 and 2 million copies during that time. So it really puts baby at high risk. PrEP is something that's underutilized, especially in women. The American College of Obstetricians and Gynecologists and the World Health Organization all agree that any viable prevention options, including PrEP, should be encouraged for women at risk for HIV, especially during pregnancy and breastfeeding, given the increased risk of HIV acquisition during pregnancy and the potential for perinatal transmission with maternal seroconversion during pregnancy. So for PrEP, There are a few other medications out there, but we'll focus on today is a pill. It's called Truvada, is the brand name, and there is a generic out there with tenofovir disoproxil fumarate and emtricitabine. It's basically 2 antiretrovirals in one pill. And what you do is you take that tablet once daily. It's highly effective. You get over 90% reduction in HIV transmission from sex and over a 70% reduction in transmission for people who are injecting drugs. The one caveat to this is that adherence is critical. So if you don't have high enough drug concentration in the body to prevent HIV from incorporating itself and establishing a permanent infection, you're not going to get the protection there. It is covered now 100% by the Saskatchewan Drug Plan and for NHB, so folks with treaty status, and family physicians and nurse practitioners can prescribe this without IV approval. The exceptional drug status was taken off of it in Saskatchewan a couple of years ago. So I'd really encourage anyone who is a prescriber to look more into PrEP after this presentation. If the more people prescribing it and considering it for patients, the better, and the more impact we can have on driving those new diagnoses down. So for women, you have to take the Truvada for 20 days before the protection is offered for receptive vaginal sex, and it would be 7 days for anal sex. You want to continue PrEP until 28 days after the last exposure. There is an on-demand style of PrEP out there, and it's not expected to confer protection for those at risk of acquisition through vaginal exposure. So the on-demand style of PrEP is basically taking 2 tablets of the Truvada 2 to 24 hours before exposure, and then taking 1 tablet for the next 48 hours after the exposure. And given the above statement about how long it takes for the drug to get into the vaginal tissues, that approach really isn't expected to work. That's more of a approach that's been studied and kind of confirmed to work in the MSM population. There is also a drug out there called Descovy. So it's very similar to Truvada, but it has tenofovir alafenamide in it instead of tenofovir disoproxil fumarate. And the benefit to that is that giving it in that form of TAF, it concentrates more intracellularly, and then therefore they're able to give a lower dose. So they're not seeing any kind of renal toxicities from that form of tenofovir or decreases in bone mineral density. So that's sort of a consideration, I guess, for those who have kind of a compromised renal clearance. At this time, though, they haven't recommended to use it in pregnancy, but that may be something that changes in the near future, because there has been some pharmacokinetic data that's come out recently for TAF use during pregnancy. So stay tuned. If you have some patients that are renally compromised, this may be an option for them soon. So what are some of the indications for PrEP? So if someone's having condomless sex with a partner whose HIV viral load is detectable or it's unknown, if they've had a recent sexually transmitted infection, if injection drug use where equipment is being shared, or if they have a partner who's using injectable drugs, you don't know if that partner is sharing the equipment or if they're exclusively using their own equipment. So I think there's a bit of risk there for the patient. If the patient's engaged in commercial sex work, if they have multiple sexual partners, or really anyone who feels that they're at risk for HIV. I did put a statement down there to keep in mind the risks for transmission are often underreported. Sometimes people don't think they are at very much risk, or they don't feel comfortable sharing some of the above with the healthcare provider. One thing I wanted to highlight too, there's the concept of U equals U, so undetectable equals untransmittable. So if a positive patient is taking their antiretrovirals regularly and their HIV viral load becomes suppressed, they did do several studies and found they analyzed thousands of unprotected sexual acts and found that those who were suppressed consistently didn't pass HIV on to their partner. So if, let's say the woman has a partner who is HIV positive and that partner is suppressed on their antiretroviral therapy, it really would, I would say, would be optional, and it's not really necessary for the patient to be on PrEP. But sometimes we've got couples that come in and they're really nervous or apprehensive about the negative partner becoming positive. We'll still offer PrEP to people if it gives them peace of mind, but really it's not necessary if the partner is, consistently taking their medication, has a suppressed viral load. If the patient has a partner that's been newly diagnosed and they're just starting their antiretroviral therapy, you could consider giving the woman PrEP to take until their partner is suppressed, stably, just sort of as a bridge to provide with some protection. So I've just listed some of the trials that have looked at U equals U at the bottom there, if anyone's interested and wants to look more into that. So you've got a patient and you've decided, based on some of the indications listed earlier, they might benefit from PrEP. So we'll talk about some of the important points to consider when you're initiating someone on PrEP. So we've already kind of done that baseline assessment. They're at risk for HIV. You're going to talk to them about starting PrEP. You're going to perform a few baseline lab evaluations, and you'll see a chart that's included on the next slide that kind of has the time when you withdraw certain tests. It's kind of a good quick reference. You're going to want to have a negative HIV test recently, so in the last 1 to 2 weeks. You really want to confirm that that patient is in fact negative before you start the Truvada pill. As if they were positive already, Truvada isn't enough to keep the virus in check on its own. And what can happen, you can actually have resistance develop. So the virus kind of starts to outsmart the medication and produce mutations that make the medication not work as well. So what we would normally do is have people on 3 antiretroviral medications to treat their HIV. And so Truvada won't be enough. So just being really careful about making sure that person is negative before you actually put them on PrEP. And so again, we want to evaluate for signs and symptoms of acute infection within the last 12 weeks. If you think that acute infection might be going on, you may want to consider delaying PrEP and then repeat the test in 1 to 3 weeks, just to see if they did end up becoming positive. I would say use your clinical judgment in this scenario, though, because someone might be highly at risk for acquiring HIV. So if you think that the risk is too great to wait before you repeat that test, you might decide to go ahead with PrEP. You want to make sure their creatinine clearance is over 60 mils a minute, because as of right now, Truvada is the only one that's indicated for PrEP in pregnancy. Pregnancy as well. And I would counsel the patient about other harm reduction strategies. So condom use, using clean equipment if they're injecting drugs, that sort of thing. Talk about the benefits of PrEP and then also the adverse effects, which we'll talk about in a couple slides, and the importance of adherence. Also ensure that the patient does have drug coverage in place. There's nothing more frustrating for a patient than getting a prescription for something and then heading to the pharmacy and told that it's not covered. Luckily in Saskatchewan, as long as you have a valid Sask Health card, you are covered 100% for PrEP. And then folks that have NH or treaty status as well are insured at 100%. So that really helps overcome one of the barriers to initiating PrEP. So this is a chart and a schedule of when you want to do the different tests. So baseline, we're going to do an HIV test, test for hepatitis A, B, and C. If they're non-immune to Hep A or Hep B, I think that's an opportunity to immunize them at that point in time. And hepatitis C, if somebody's positive, we can treat that now with within 8 to 12 weeks, we have medications that can clear Hep C. Also going to do some STI testing, CBC, creatinine, urinalysis, and a pregnancy test as well. And then do that clinical evaluation for signs and symptoms of HIV. At the 30-day mark, we're going to do another HIV test. So the purpose of that is to catch anyone who may have been seroconverting during that time frame. So you can kind of catch that early, and if they are positive, you'd stop the PrEP and refer them on to somebody who's familiar with treating HIV. We'd also do another test with the creatinine at 30-day mark, just to kind of make sure that their kidneys are going okay on the Truvada. And then again, at every touch point, you're doing an evaluation for signs and symptoms of acute infection. And then after that, the lab work becomes a little less frequent. It's every 3 months. We're going to always be doing that HIV test, screening for STIs, doing that creatinine again, and the pregnancy test every 3 months as well. And then the clinical evaluation for any acute symptoms of HIV. So it is really important that the patient does complete their lab work at the baseline 1 month and every 3 months while on PrEP. If you're finding that somebody's not kind of following through on their end, you'll have to think about whether you want to continue the PrEP or not. So you kind of have to consider their risks for actually acquiring HIV versus, kind of the benefits and risks of continuing or not. At follow-up visits, we're always kind of checking for symptoms of seroconversion, adherence. It's super important if they're not taking it 6 to 7 times per week in women, you're not going to get the protection. You can always evaluate if there's a continued need for PrEP. So maybe their risk has kind of dissipated in time. So you can always stop it at a certain time. Of course, remember that they need to continue it for 28 days past the last exposure to HIV. Review the STI prevention, and then check out their blood work. So probably a lot of you guys are familiar with signs and symptoms of acute infection, but I think this is kind of a nice chart that highlights the most common signs you might see: so fever, weight loss, GI upset, lymphadenopathy, pharyngitis, or myalgias, arthralgias. Those are kind of the most common you'll see. So if somebody does have acute infection, advise them to use condoms and then temporarily stop the attempts to conceive. It's not that they can't become pregnant if they are HIV positive. We just want to make sure we get them on the appropriate antiretroviral medication to treat their HIV. If someone's on treatment for HIV, their risk of transmitting to the baby is actually less than 1%. So we just want to make sure they've got all the right things in place before they attempt to conceive if they are positive, because then we can mitigate the risk of transmission to the baby. Also, we would recommend if someone has a young child that they become positive to stop breastfeeding. There is a high risk, it's probably one of the highest risks of transmission between, to the baby. You can get up to 30 to 40% transmission through breast milk. And then, of course, refer to an IV specialist to get them into care. So when should PrEP not be used? So if you don't know the HIV status, only people who are testing negative should be using PrEP. And again, you want to have a recent HIV test done within the last couple of weeks for sure before starting. Use a 4th generation test. So using point of care tests don't really cut it to rule out infection. I would actually do a blood draw and to confirm their status. If someone's displaying signs or symptoms of acute HIV infection, you don't want to start PrEP because, as we discussed before, resistance could develop easily on Truvada only. Caution with hepatitis B patients. It's really important to be aware of the patient's Hep B status. So if they've got active Hep B on board, tenofovir does actually treat the hepatitis B. But if you didn't know the patient was Hep B positive and you had them on Truvada and then you stopped it at some point, you could risk a flare in the hepatitis B with withdrawing the tenofovir treatment. So it's not that you can't use PrEP in Hep B positive patients, it's just you have to be aware of that status so that you don't stop the tenofovir all of a sudden and cause a flare. Right now, we don't have Descovy approved for PrEP use. That's covered. It's Health Canada approved for PrEP use, but it's not listed on any of the provincial formularies or NIHB, so there's no coverage for it yet. There may be though soon, so we're kind of limited to providing PrEP in the population that has good, healthy, functioning kidneys and a creatinine clearance over 60 mils a minute. So some concerns with PrEP use, I've already said this a few times, there is a risk for resistance. Some of the medications may not work as well against the virus. They might be on more complicated regimens. If the patient becomes like HIV positive while on PrEP, the Tenofovir and Trocycline alone are not enough to suppress an active virus. The patient can another concern with PrEP use is that some patients may use PrEP instead of condoms. So, they'll think, okay, I'm on PrEP, I'm safe from getting HIV, I don't need to use condoms anymore. But we really look at this sort of as an additive approach to provide extra protection. Condoms are still important to prevent STIs, because PrEP doesn't do that. So just make sure you're providing proper counseling to any patients you're seeing about that. And I think I've also highlighted these previously. Yeah, doesn't protect against STIs, and the patient needs to have consistent adherence to achieve protection. So 6 to 7 days per week. This is different in the MSN group. We're not really highlighting that topic today, but in women it is important to do 6 to 7 days a week for adherence. So the benefits of PrEP, you're getting greater than 90% protection against acquiring HIV if you're taking it as prescribed. And another good thing is we have a good amount of safety data with it, because it's part of a regimen that some folks use in active treatment of HIV. And so we actually have a lot of data around pregnancy and breastfeeding, so we can assure patients that it's safe and okay to use. Some of the side effects from Truvada include some GI upset in the first few days, so maybe some nausea or vomiting. If that's going on, they can always treat with some gravel, PRN, short-term use. And then usually after a few days, if the patient does experience those symptoms, it usually goes away. So it's sort of kind of that PrEP start syndrome, and it'll settle down in the majority of cases. In terms of kind of long-term toxicities, as I mentioned before, so TDF or tenofovir disproximal fumarate has been kind of indicated as causing some renal toxicity. So proximal tubulopathies or Fanconi syndrome. I would say in terms, looking at our positive population, we do monitor their lab work frequently to watch for this type of thing happening, and it really doesn't happen very often. We've got probably 1,600 patients that we follow in Saskatchewan, and I have seen it come up once in a while, but it's not common at all. So I think providing some reassurance to the patient on that is important. If they're reading kind of information that it could cause that might scare people off from taking it. There can be some decreases in bone mineral density, but with PrEP, they've found upon discontinuation, usually within 6 months, that bone mineral density does return to normal. And then there's also a potential lactic acidosis on Truvada. I have not actually seen this myself, but again, I guess I work in the outpatient area, and maybe inpatient they see this the odd time, but I've actually never seen anyone have this occur. So back to some safety in pregnancy and breastfeeding and with the infants. There's no evidence of renal toxicity for infants who are exposed in utero. There's lower Z scores for length in PrEP exposed infants, but no difference at 1 year. There is some conflicting data around possible preterm birth when it's been exposed to PrEP, but I think the benefit is still going to outweigh the risk if we can prevent infection. mom and baby. For the moms, there's minimal and reversible effects on their bone mineral density and renal toxicity. And for breastfeeding, there's minimal amounts of that medication that actually makes it into the breast milk. So the importance of adherence, I think we've kind of beaten that one to death already. And in the second and third trimester, it's particularly important that a woman is taking the medication as best they can for as many days as they can in a week, because our volume of distribution increases. So the way I think of it is you need kind of more drug to fill up the tank, is how I would explain it. So if they're getting kind of suboptimal levels during those times, they're going to be more at risk of not getting the protection. If you're finding that there's ongoing trouble with adherence, I would probably focus on other forms of protection for that patient. So adherence, it's a big part of this. So we want to consider any barriers that the woman may have to adherence at the initiation stage. So address concerns that they might have around PrEP use, including safety and efficacy data. Each patient I found has their own unique challenges with adherence. You really have to tailor a plan that suits the individual. Some of the challenges we have with adherence is people kind of just get sick of taking the pills. A lot of young people aren't on pills every day, so it's kind of a change to their routine. The patient may not perceive themselves to be at high risk of getting HIV, so that buy-in is not there. There's also some stigma, I guess, to be on this medication. It is one of the medications that is used for treating HIV. So sometimes, patients are apprehensive about going into a pharmacy and picking up these pills because they're worried someone's going to think they're positive, or they're worried their friends might find this medication and know what it's for, that kind of thing. Cost can be an issue. In Saskatchewan, for most cases, it is covered. There are some situations, like if you have an out-of-province patient who's living in Saskatchewan and they're insured by Alberta or BC or whatever, that can sometimes be an issue. But there are some ways we can kind of work around that. They might be facing some misinformation about PrEP. They may have mental health challenges that kind of interfere with their ability to take their medications regularly, or there may be intimate partner violence. One thing I would like to highlight, though, PrEP is something that the woman can take without the partner even being aware of her taking it. So if she doesn't have the choice of her partner using condoms for protection against HIV, she can at least take this pill and have some protection that way. So these are some of the adherence strategies I've kind of come up with. And again, it's important to kind of talk with the patient, what barriers they might be facing to adherence. I've kind of found over time everyone has different reasons, and usually if you have a good relationship with the patient and they're trusting of you and comfortable with you, they know kind of why the adherence isn't there, and they can identify that themselves. And then if they can share that with you, then you can kind of work together to come up with some strategies that might help them be a little bit more adherent. So sometimes things like bubble packing at the community pharmacy, if they have like one of those plastic pill organizer containers or pill box. Some folks I've given little keychains too, so it's like a little container with a keychain on it, so they can attach it to their purse or their backpack, or it's small enough to put in a pocket, that kind of thing. So if someone's out and about and they forgot to take it at home, at least they've got kind of a spare dose on hand, they can take it then. Another key thing we often tell people is to place the medication under something that you do every day. So whether that's brushing your teeth or whatever, putting the pills kind of right by your toothbrush, just something to kind of remind you with your regular routine to take that medication. Some people will set an alarm on their phone, and that's helpful. Or some people even set 2 alarms, so if they don't take it after the first one, the second one will kind of remind them. There's apps out there as well people can download and can even track, how many times you've taken your pill or not. If the patient is comfortable with it, in terms of confidentiality, they can ask family members or friends to remind them. Planning ahead, if somebody's traveling, that's something that's important. A lot of people kind of remember to pack everything else, but they forget the pills. So just kind of thinking of that ahead of time. Keeping a backup supply in their purse or a backpack is a good idea. Community pharmacies can set up auto refills. So if someone's forgetting to phone in and request that refill, auto refills can be set up to help with that. Sometimes we'll pair, people will be receiving methadone daily at pharmacies. So we might pair that medication with the methadone administration at the same time. And a really important thing is to keep clinical appointments with the care team. So if you're, if the patient's engaged and seeing the care team more often, I find adherence is usually better. So there are some kind of interesting options for PrEP in future. So I did talk about Descopy, and that is something that may kind of come along in terms of something that's kind of covered for patients. Would like to see that so that we're not excluding the folks who have renal insufficiency. And then there's a couple really cool things that will be coming along. They're long-acting formulations, and I think these will really be game changers for prevention. So there is one medication called Capotegravir, and it's an injectable antiretroviral medication. And I think they've just kind of moved into the phase 3 study point with this one, so it could be kind of coming soon. And I think, I'm not sure if they'll decide on, giving it every 4 weeks or every 8 weeks. I think they'll be looking, in a prevention format to give the injection every 8 weeks. So that's really cool because, people don't have to remember to take a pill every day. They can go in, get their injection, and then kind of carry on with their life and be protected in the meantime. So I think that's going to be really neat. It may take some time to get some data in pregnancy, however. Usually that comes after, a medication's been out in general use for a little while. But there will be folks who are HIV positive. The Capotegravir won't be given by itself in those cases, but as a combination with other medications. But there will be some data from folks that happen to become pregnant while being on it. So eventually we will get some data and then potentially we'll use it in pregnancy even. And there's another medication called Islatravir. It's an NRTTI, so it's kind of similar to the tenofovir emtricitabine, the NRTIs, but it has a little bit of a different mechanism of action. They're looking at different modes. This one hasn't, I think, come along quite as far yet, but they're kind of thinking about doing like a monthly pill or an implant of this medication. And again, that kind of takes care of the adherence piece of things. So definitely some exciting things coming along. And so you might be asking yourself, where can patients actually access PrEP? I think this is something that can definitely be improved upon, but we've got a few sites in Saskatoon. Saskatoon offers PrEP services to folks. You just phone for an appointment and they can get you set up there. And the University of Saskatchewan Student Wellness Center is offering PrEP to folks that go in there. And then I'll just highlight like any family medicine physicians or nurse practitioners, anyone who's got prescriptive authority can go ahead and prescribe PrEP. So I would encourage anyone who's listening today, if this presentation has piqued your interest at all, to really look into prescribing it to your patients. It's really not a difficult kind of concept. It's pretty easy to do. So I think pretty much anyone can come along and offer this to patients. And then I did confirm with one of our infectious disease physicians, Dr. Shakil Pir Mohammed. He has been holding the odd PrEP clinic lately. They are quite busy with kind of their general ID patients and the patients that are HIV positive already, but he has started offering the odd PrEP clinic. And I asked him, what would the wait time be to get in to see him? And he actually said because there's a lot of clinics being done virtually now, he's often able to see people within 1 to 2 weeks, which is pretty good. Usually it can take a few months to get in to see our our infectious disease physicians. So that's kind of nice. He's able to offer that. I'm sure there's other practitioners in Saskatchewan that are offering it as well. But I think the more we offer this to patients, the better, and the better able we're going to be able to bring down our high rates of infection. So, in conclusion, I'd really like to see PrEP being offered to women at risk more often for, acquiring HIV who are trying to conceive in pregnancy, postpartum, or in breastfeeding. It's highly effective, as you saw, if it's taken with good adherence. The side effects of PrEP are really quite minimal. It's quite a safe medication to take. And then again, in Saskatchewan, given our high rates and the high proportion of females becoming positive, I think this is an important prevention strategy to help combat the ever-rising rates of HIV. So with that, I'm just going to open it up for some questions. If anyone has thought of anything or along the way, I'd invite anyone to chime in now.
Thank you so much, Carly. That was a lot of information and great and needed. We have quite a few questions. So first I'll start with what informs the recommendation for continuing PrEP for 28 days upon discontinuation? In your experience, do patients actually follow this advice?
Yeah, so I would say, I think it's what informs that decision is basically, the maintenance of the concentrations in the vaginal tissue have to be, I'm not too sure with the time range can actually vary between the MSM group. It's shorter and the actual kind of the women's group. So I'm not actually sure where they came up with that recommendation, but anyone who's providing PrEP and following up with patients, we definitely would discuss that with the patient and make sure they're aware of that so that they can attain the most optimal protection. So yeah, it kind of depends upon the patient, what is their adherence like in the first place. If there's someone who's really adherent, I'm finding, they will kind of adhere to that. If we have, sometimes people start on PrEP and then they kind of fall off with it after a while. So I guess it kind of really depends on the patient, but that's why it's really important to do those touch base points with the patient every 3 months as they get going and kind of do those check-ins with them.
Great. So next question, should PrEP not be used in hepatitis C positive patients like hepatitis B, or just if the hepatitis C positive patient has decreased renal function?
Okay, yeah. So these medications don't work against hepatitis C. They just work against preventing HIV infection and treating Hep B. So as of right now, we don't actually have kind of a pre-exposure prophylactic kind of medication available for hepatitis C. But it is important to kind of do that regular testing for folks who might be at risk. And I think, initiating treatment in those individuals as soon as possible really will help limit the spread. So there is kind of this concept about treatment as prevention in HIV, and I think you can kind of apply that to Hep C as well. If you have people who are treated and you're clearing the infection for hepatitis C, you're not going to have it spreading around as much. The longer someone is untreated, the more risk there is that other people are going to get exposed. So yeah, unfortunately right now we don't kind of have a preventative strategy in terms of medication for hepatitis C, but we do have some really good medications for treatment. And if we're testing people frequently, we can find those positives and get them treated and prevent more transmission in community.
Thank you. Next, we have, what are your thoughts on the community pharmacy vial reading, take one pill daily for prevention to help with the stigma associated with treatment versus prevention? If the person is afraid someone will find their PrEP bottle, maybe this might help alleviate a bit of that anxiety.
Yeah, that's a good thought. Yeah, to put on there for prevention. We've even had some people who are really concerned about people finding out what they're taking. They'll take the pills out of the bottle and they'll put it in like some of those keychain containers we give them, or they might put it in a vitamin bottle as well. And then, you know, people may not know kind of the difference. I'd say from like a pharmacy perspective, I kind of like medications in their label vials, just for safety reasons. But at the same time, if someone's so highly concerned that someone else will come along and discover that they're on this medication, I think, you know, if they need to keep it in a different container, I think that's fine. Whatever they have to do to feel comfortable about that. Some folks don't have the privilege of living kind of by themselves in a home. They might live with a lot of other people at the same residence. So, you know, just protecting the privacy, I think, is really important as well.
Thank you. Next question. What parenteral route is Capotegravir? I'm sorry, I cannot pronounce drug names, but
yeah, no problem. So Capotegravir is given by IM, so it's an intramuscular injection, and it's given into the buttock area. They are looking at other areas of administering that injection, though, because I think the idea is to kind of de-medicalize PrEP, make it accessible for patients. So the fact that they would have to go into a healthcare facility to receive the injection, I think kind of detracts a bit from that option away. So they are looking at, you know, can they inject that into the thigh instead? It can't be injected into some of the smaller areas like in your arm just because of the volume that's required to give. But they are looking at, you know, the front of the thigh so that, you know, perhaps the patient could be the patient could be educated on how to administer that themselves and kind of avoid having to go in to the clinic to actually receive that injection.
okay. I have a bit of a long question here, so in the chat too if you want to follow along. So hey, Chloe and others, I'm just working on PrEP module for CPD-PP. Here's the information that I found on discontinuation. For those discontinuing daily PrEP, it remains unclear for exactly how long PrEP should be taken after the last exposure. In the absence of definitive data, the panel who published the Canadian guideline on HIV pre-exposure prophylaxis suggests a conservative approach of continuing PrEP for up to 28 days after the last exposure. MSM with a long duration of PrEP adherence may require as little as 2 days. Pharmacokinetic models suggest that drug levels consistent with greater than 90% risk reduction persist for 7 days after PrEP discontinuation in MSM, but this finding does not indicate when it is clinically appropriate to stop PrEP. Thank you so much for sharing that, Kelsey.
Thank you, Kelsey. Like, I didn't pick up the recommendation. I'm like, I didn't look that deeply into the reasons for it, but yeah, I know there is kind of a variable number of days out there, like she said, like as little as 2 days or up to 28 days. So I think, yeah, if you want to err on the side of caution until that becomes kind of more clear, maybe in future studies that come along, I would maybe advise, especially the women, to continue for 28 days if possible, to kind of get the best benefit, best protection.
Right. So I'm personally wondering whose role should it be in the prescription and overseeing PrEP patients? Is this something that needs to be specific to specialists, or is this something that can be available throughout the province or more accessible?
Yeah, I think that's a fantastic point. So there hasn't been a huge uptake amongst a lot of, you know, family physician providers in community with PrEP. There have been some that have kind of championed it and gone ahead and, you know, provide that option to their patients. And so I think there's been some kind of conception out there that this is sort of just for specialists to use, and, you know, they're the ones who should be prescribing it. But it's really quite a straightforward procedure, and pretty straightforward follow-up. I think really anyone who's prescribing out there would be eligible to take this up into their practice and offer it to patients. So I think just trying to get that awareness about PrEP out there and the education out there, and then people would feel comfortable to go ahead with that. I know the RX Files group is actually working on promoting PrEP to family physicians, and they're kind of working on that idea right now. So they've got good contacts with many different physicians throughout the province. So I'm kind of hoping that will take things off a little bit there, and we'll see a little bit more PrEP use in community, hopefully.
Sounds good. And then I guess one last question that we have is from Paulette, and she's wondering if you'd be available to do this presentation for a group of family physicians via WebEx.
Absolutely, yeah. Anyone who will listen, I'll talk about PrEP. So, yeah.
Wonderful. Okay, well, I will share Carly's information in the follow-up email if you're interested in contacting her for maybe trainings with your own organizations. If nobody else has any questions, then I might just finish up.
Okay.
All right, so thank you, everybody. Thank you so much, Carly, for sharing your knowledge and all of this information with us today. I want to remind everyone that this presentation was recorded, and there will be a link sent out in a follow-up email for later viewing. And I will also include a copy of the slides, which Carly has generously offered to share in case you wanted to keep those notes as well. When you leave this meeting, you will be directed to an evaluation link when you close this Zoom window. Completing these evaluations helps us determine the focus and format of our programming and allows us to better support you as professionals in this field. Finally, the Saskatchewan Prevention Institute has a wealth of resources specific to HIV and pregnancy, as well as other STBBIs and pregnancy that are available free of charge through our website. I am currently offering free shipping on sexual health resources within Saskatchewan as well. So if you are interested in accessing that benefit, please send me an email. You can learn more about our resources by visiting our website, www.skprevention.ca. And if anybody was looking at the question section, you will also note that I have an upcoming webinar with Dr. Kelly Gartner on HCV and pregnancy on May 12th. So I will be sending out registration information for that as well. So once again, a very warm thank you to our speaker today, Carly Pozniak, for sharing their knowledge and their work with us and for informing us on this very important topic, and hopefully new strategic use of PrEP and prevention for HIV. Thanks so much, Carly.